has been a constant and calming force amidst the fast-paced changes the country has faced, making it even more inconceivable to think about what happens when she dies. Born in 1926, she was expected to live a relatively normal life. Well, normal at least by royal standards. As third in line to the throne,
Can you please mute?
Okay, as you have had a colleague say, if you are joining the class, please mute your microphone so that, except if you're communicating to the class. Okay, so we started yesterday the lecture on these beta-lactam antibiotics, and we talked about the structure. We talked about the need for the integrity of the structure of the beta-lactam antibiotics for them to continue to work. We also talked about how the beta-lactam structure is disintegrated by particularly penicillinases, also referred to as beta-lactamase enzymes, and that this is a main mechanism of resistance which renders these beta-lactam antibiotics ineffective. Also, we shared the different types of beta-lactam antibiotics, different classes, but also because we were looking at penicillins in particular, we also looked at the different, the subclasses of penicillins. And so after that, we looked into the organisms, and because having knowledge of these organisms in terms of their classification, and also I referred to the fact that one needs to know the common organisms per condition, the type of infection, which, if you put this together, knowing the organism in terms of structure, knowing the conditions this organism is most associated with, and knowing the antibiotics, these three pillars of information are critical in the choice of antibiotic in the management of specific diseases. Of course, when you look at the treatment guidelines, these kind of make life a lot easier. But when you have this background information about the organisms and the antibiotics, it will become much better for you, because you might find that maybe one or two drugs are not available and you have to make a choice of another drug. And so if you're to make a choice of another drug, then you need to know which organisms you're dealing with and whether this drug actually has effect against such organisms. In certain situations, the patients do not respond, or rather do not tolerate a particular antibiotic, and you have to make a choice of a different antibiotic. Now, because the antibiotics are several, and also because they do have effect on a number of different types of organisms, one might get lost in the process of selecting, and will end up selecting any drug that seems to be available, but at the end, such a drug has no effect in the management of a specific condition. And so it is therefore important for us to have the knowledge of the microorganisms, and then, of course, the drugs that are used against them, but for specific infections. Now, because we are doing clinical pharmacology right now, of course, we'll be looking at the basic pharmacology part of the module, looking at the classes of drugs, their subclasses, looking at their mechanisms of action, their pharmacokinetics, and then of course their adverse drug reactions, the common ones. That information will be critical. But then it all comes down to choice. At the end of the day, a patient comes, they have an infection, and you are to make a choice of which antibiotic to use. Now, when guidelines are available and they tell you, okay, for the treatment of pharyngitis, we are going to use benzyl penicillin. If you see that in the guidelines, you are comfortable on why benzyl penicillin is being used, because you understand the mechanism of action, you also understand the type of organism that is there and why benzyl penicillin is chosen. And if it so happens that there's no benzyl penicillin available, then you can choose another drug, again, because you know that, okay, we are dealing with streptococci. Which other drug should I use in the management of streptococcal infections? And say if you have, say, because penicillins are used majorly here, if the person reacts or does not tolerate the penicillins, now you'll wonder, so where do I go next? Is it a hypersensitivity reaction, or is it a penicillin simple rash? Can I go to cephalosporins? And if you can't go to cephalosporins, where else will you go? Now that it helps when you know the disease and you know the condition, you know the antibiotics that should be used against that particular disease. Okay. So in the notes, in the slide notes, this table gives you the diseases, and then that table explains on the classification of the organisms. Okay. I know that you have done microbiology as we discussed on Wednesday. It's not hard for you to, classify these organisms, but you should practice it because it will come in handy for you when, discussing or making choices of antibiotics. But we looked at the typical bacteria on Wednesday, and there we looked at the aerobic and anaerobic gram-positive and gram-negative organisms. What we did not look at is chlamydia, because chlamydia are also bacteria. Rickettsia are also bacteria. Mycoplasma are bacteria. Spirochetes are bacteria, and so are the mycobacteria. But these have different structures from the typical bacteria. And the main difference between these organisms, apart from the spirochetes, and the typical bacteria, is the peptidoglycan structure. Because the beta-lactam antibiotics work by inhibiting the synthesis of the cell wall of these bacteria. So those organisms that lack this structure, that lack the peptidoglycan structure, or the peptidoglycan structure in the organisms exists in very small quantity and is not particularly critical for the survival of the organism, these beta-lactam antibiotics will have no effect whatsoever against such organisms. For example, when you talk about chlamydia and you talk about mycoplasma, these even rickettsia, these organisms lacking the peptidoglycan structure, you can't use beta-lactam antibiotics against them. But for the typical bacteria, the beta-lactam antibiotics can be used, but it also matters which type of organism you're dealing with. Are you dealing with coccus, gram-positive, gram-negative? Is it aerobic or anaerobic? All that information is critical. So we need to know, to have this information as foundational in the clinical pharmacology that we are going to be studying. And then after that, I would like you to have some knowledge of these types of infection. The ones that I will deal with for this particular course module, we shall deal with urinary tract and respiratory. I think that will be enough, but you can always use the table for others. What I have not added yet is we have also information on meningitis. So when you go to your clinical rounds, you're going to come across these diseases and the organisms and how to deal with these organisms. So this information is critical. And I'm going to leave you, of course, to study this table and be familiar with the information therein and that table as well, so that you can marry the two, and then you can bring in the completion of knowledge by bringing information on the antibiotics that are to be used. So yesterday, we talked about these penicillins, the anti-staphylococcal penicillins and extended spectrum penicillins. And the information on this slide does tell you where anti-staphylococcal penicillins can generally work because they work against gram-positive organisms, aerobic ones. You can see also with the notes here that these anti-staphylococcal penicillins will not work against enterococci, even though those are also gram-positive organisms, and they are cocci, they are cocci, but these drugs will not work against them. They will not work against gram-negative cocci. They will not work against gram-negative rods. And so when I'm asking questions and I present a case of a patient, it might require you to reason what disease are we dealing with. Of course, I will be giving you a diagnosis because this is not to study diagnosis, how to diagnose. I'll give you the diagnosis, but then after giving you the diagnosis, I'll ask which organism is likely to be the cause of the infection and which drug are you going to use against that organism. Then on that same case, I'll ask, in case the organism is generating beta-lactamases, which drug are you going to use? And I'll be giving you the options. And then after that, I'll make it better by asking you to, if possible, if time allows, asking you to explain your answer. That means that you need to have a complete knowledge of your choices rather than guessing from a multiple choice, guessing options from multiple choice. Okay, so we looked at those, at the anti-staphylococcal penicillins, the penicillin itself, and then the extended spectrum penicillins. And then I think what I dwelt on was beta-lactamases and what beta-lactamases do. And then I wanted to talk about, I think I did talk about methicillin resistance and what methicillin resistance means, and methicillin resistance, which organisms are associated with methicillin resistance. These are mainly gram-positive organisms, particularly Staphylococcus aureus, and what that means when you have methicillin resistance and Staphylococcus aureus. And I remember also informing you that once such a resistance happens, the organism also has resistance against many other antibiotics. Okay, so we went through this structure of the beta lactam, of the gram-positive and gram-negative organisms, and looked at the difference in structure between them. And also this applies when it comes to selection of antibiotics. One needs to know whether you're dealing with gram-negative or gram-positive organisms. I talked about the mechanism of action of the drugs working against the transpeptidase, which is the penicillin binding protein. And we looked at what the transpeptidase enzyme does in building the peptidoglycan structure, a process that is inhibited by these beta-lactam antibiotics. And because the peptidoglycan structure is critical for the survival of the organism, without the peptidoglycan structure, the organism will undergo lysis and it will become non-existent. Resistance, we talked about beta-lactamases, and I think what I want to do today is to tell you about the different types of beta-lactamases. What do beta-lactamases generally mean? Once they are there, what does it mean for beta-lactam antibiotics? The question would be, would you use another beta-lactam antibiotic if you have a beta-lactamases generated by the organism? That is what we are going to look at now, and we shall take it forward from there. Okay? Any questions? I just wanted to give you heads up of what we went through yesterday, because I did not upload the video and the slides for you. Any question? Okay, there seems to be no question. And the class is poorly attended today, but no harm, we'll go ahead. Okay, so the resistance against beta-lactam antibiotics occurs, number one, by inactivation of the antibiotic by beta-lactamases. Now, some beta-lactamases are relatively narrow in spectrum. Now, that is also important to know. Beta-lactamases from Haemophilus influenzae, Staphylococcus aureus, and E. coli deactivate penicillins more than cephalosporins. That would mean that some cephalosporins might be used in such circumstances where the beta-lactamases from these organisms are generated and render the penicillins inactive. Okay. Beta-lactamase is produced by Pseudomonas aeruginosa and Enterobacter species, effective against penicillins and cephalosporins. Now, that also shows you that while you might go to, if you have H. influenzae resistance against penicillins, you might try cephalosporins. The same goes for Staph aureus and E. coli. But if the organism you're dealing with is Pseudomonas or Enterobacter, and you have resistance against penicillins, expect resistance with cephalosporins as well, okay? Because these organisms, they are beta-lactamases, enzymes that that hydrolyze the beta-lactam ring in both penicillins and cephalosporins. And then we have the extended spectrum beta-lactamases, which deactivate penicillins and cephalosporins. Again, what I've introduced now is not simply beta-lactamases, is not simply beta-lactamases, but also I've introduced to you the extended spectrum beta-lactamases. Now, do not confuse these with extended spectrum penicillins. I know sometimes when students do not revise and get to the deep knowledge of their notes, people mistake extended spectrum penicillins with extended spectrum beta-lactamases. Okay, so we know what beta-lactamases do. Okay, carbapenems are highly resistant to hydrolysis by penicillinases and cephalosporinases. Okay, the other term I'm introducing now is that these beta-lactamases, some are generally penicillinases, others are cephalosporinases, but they are not carbapenemases. Yesterday we looked at carbapenems. So the carbapenems might have resistance against these beta-lactamases, and therefore they are able to work against those specific microorganisms. But of course, organisms, these carbapenems are also susceptible to hydrolysis by carbapenemases. Now that means that we are having different beta-lactamases. Even though they have this common term, penicillinases or beta-lactamases, they differ, okay? Some will be active against penicillins, but not against cephalosporins. And then some will be breaking down both penicillins and cephalosporins, as we have seen with the extended spectrum beta-lactamases. And then others will be active against the carbapenems as well. Now, the carbapenems is where we have imipenem, meropenem, dorotapenem, and ertapenem. I will give you those drugs as well. These drugs are used commonly in the units where patients are admitted with severe conditions in the ICUs, intensive care units. So they are preserved there, but then resistance against them is also developing. And it is by penicillinases that break down carbapenems. Any questions about this mode of resistance? Any questions?
No, doctor.
Okay, right, I'll proceed. We'll now look at the modification of the target penicillin binding site, because this penicillin binding site is basically the last step in the multiplication of the bacteria to have its cell wall, and resistance to this through this is important. Methicillin resistance is based on altered penicillin binding protein target sites, and that results in reduced affinity for beta-lactams. This type of resistance is in staphylococci, pneumococci, and enterococci. What is common about these organisms? Somebody?
Doctor,
Yes,
is it because they're all gram-positive?
that's right. They are all gram-positive organisms, okay? But also, they are also cocci, but majorly they are gram-positive organisms. So this type of resistance is majorly found in gram-positive organisms. With the gram-negative organisms, what we have there majorly is beta-lactamase generation. But as you have seen, the beta-lactamases differ, all right? There is a spectrum of beta-lactamases, and some of them are effective against all beta-lactam antibiotics. Okay, then there is impaired penetration of drug to target penicillin binding protein. This type of resistance only occurs in gram-negative species because of their impermeable cell wall membrane. Now, as you remember, the gram-negative organisms have the outer membrane, they have the peptidoglycan structure, and then the inner plasma membrane. Now, the penetration to reach the penicillin binding protein, which is stationed within the inner membrane, might be difficult in various ways. The impermeable cell wall, the beta-lactams across the outer cell wall via porins, modification in the porin structure or downregulation of porin production can result in resistance. Downregulation means that instead of having, let's say, on this organism, the usual 50 porins where the drug is supposed to pass, it's now producing 10 of them. So very little drug is going to have access, okay? So even though some drug reaches, the concentration will be so little for it to stop the synthesis of the peptidoglycan structure. And so this is a mechanism of resistance that is common in these gram-negative organisms. Poor penetration alone is not sufficient resistance. Why? Because one can increase the dose. When you increase the dose, it will allow a lot of the drug to get in. But if there is, in addition to poor penetration, you have beta-lactamase as well. Beta-lactamase is generated. Even the little drug that has been able to squeeze through these porins to reach the active site, the beta-lactamases will be there waiting to consume the beta-lactam ring to render the antibiotic ineffective, okay? And then the fourth mode of resistance is efflux. Gram-negative organisms may produce an efflux pump. These pumps consist of cytoplasmic and periplasmic protein components, okay? So these are the 4 types of resistance. But the most common and most important the beta-lactamases and methicillin resistance. Okay? Any question on the modes of resistance?
No, doctor.
Right. I want to ask a few questions. When a patient comes and they have, let's say, a skin infection, and you find out that the skin infection is caused by staphylococci, which antibiotic are you going to choose from amongst the beta-lactams?
Doctor,
Yes.
anti-staphylococcal penicillin.
Yes, human, you are awake, eh? Which anti-staphylococcal penicillin can you mention?
I think it's penicillin V or methicillin if it's not resistant.
Okay. Methicillin is not found in clinical practice. It is found in the labs, okay? And which is why they call it methicillin resistance. When you take a sample to the lab, they test using methicillin to see if there is methicillin resistance. And if the organism fails to grow in the presence of methicillin, they say, there is no methicillin resistance, okay? So phenoxymethylpenicillin is also not commonly used because of, it has a number of problems in terms of absorption and things like that. But there are other penicillins that are used, these anti-staphylococcal penicillins. Somebody? You can refer to your notes. There's no problem. I'm waiting.
I'm not sure, doctor, but what about amoxicillin?
Amoxicillin. Okay. Okay. You could use amoxicillin, but your colleague chose anti-staphylococcal penicillins. Okay. Amoxicillin can also work. Okay. Amoxicillin can work, but I would like somebody to choose another anti-staphylococcal penicillin.
Oxacillin.
Oxacillin, okay? There is oxacillin, even though I don't know if it is readily available. And it also has some challenges. But there are others like cloxacillin, okay? Cloxacillin, and I think cloxacillin should be available, readily available. Sometimes in combination with ampicillin, but cloxacillin should be available. And then we have dicloxacillin and flucloxacillin, okay? Those are anti-staphylococcal penicillins, which can be used. Okay, now my next question, again, regarding this patient, supposing now they tell you that this patient has come in, we've identified Staphylococcus aureus. Okay, this patient has Staphylococcus aureus, causing these skin abscesses, and now they tell you, beta lactamase generating staphylococci are common, and so these patients' staph are producing beta lactamases. Which antibiotic are you going to use? Will you use amoxicillin? I'm giving you two options. Will you use cloxacillin or amoxicillin? And when you choose one, explain why and why not the other.
So
Yes.
I would say cloxacillin because, as I understand it, almost all anti-staphylococcal penicillins are resistant to beta lactamases.
Okay. Beta lactamases of what?
Produced by the staphylococcus.
Produced by Staphylococcus, okay. And so do you think these will resist? Okay, they are basically effective against gram positive organisms. Okay, so they are resistant against beta lactamases generated by Staphylococci. And what about amoxicillin? Will you use it? Somebody?
I'm not sure, doctor, but isn't amoxicillin susceptible to beta lactamases?
I would like you to answer that question.
I think so, meaning if we give amoxicillin, it won't be as effective as cloxacillin.
Okay, and that is true. So amoxicillin will not be able to work against such an organism. My next question is, supposing now you take this patient is not getting better. The infection seems to be getting worse. And now, of course, there is danger that the patient is likely to get septicemia or sepsis or bacteremia, which is in itself a severe condition. While the patient is faithfully taking their chlorhexidine, what are you going to suspect? Somebody?
Doctor, they're producing more efficient beta lactamases.
More efficient beta lactamases? Okay. I have recorded your answer. Thank you. Somebody else?
Okay, are they not broad spectrum penicillin lactamases?
Okay, you're saying extended spectrum beta lactamases, eh? That's what you want to say, right?
Yes, doctor.
Okay, your answer is recorded, and I think your colleague also was trying to give the same answer because he said more effective beta lactamases. Okay, recorded. Somebody else?
Maybe the staphylococci are methicillin resistant, which is why these chlorhexidine isn't working.
And that is correct, okay? And that is correct. So the staphylococci tend to produce certain beta lactamases, and that is what they produce. They don't seem to produce anything different. So we do not expect them to produce more effective beta lactamases or to have extended spectrum beta lactamases that are going to render the chlorhexidine and the other anti-staphylococcal penicillins ineffective. What the problem is that these organisms must be now having methicillin resistance, because if the patient is taking the anti-staphylococcal penicillin faithfully, but the organism, the infection continues to flourish, then we expect methicillin resistance. Okay? I think the point has been made. Okay? Now, my next question would be, if there is methicillin resistance, what do we do?
Doctor?
Yes, please.
You could give what's it called, extended spectrum antibiotics like ampicillin or carbapenicillin, or wait, carbapenicillin, sorry. And if that doesn't work and the infection continues to spread, it becomes more severe, then you'd give carbapenems.
Okay, right. This is I like the fact that this is what I enjoy when students try to respond to questions. I know we haven't gone so far, but I appreciate it when you try to create a response. To me, I like a person who's try to reason, okay, and that helps your learning, and also it helps me, highlight some important points that I may have missed. Okay, now this is what comes up. I've had your answer, but I just want to give you the correct direction. What is happening with methicillin resistance? Methicillin resistance is when you're having modification in the target site of the beta lactamases, of the beta lactam antibiotics. You're having modification at the site of action. And when this modification occurs, then these drugs are unable to attach, and the affinity between the drugs and the penicillin binding protein, also known as transpeptidase, is reduced significantly, such that in the presence of the drug, the enzyme transpeptidase or the penicillin binding protein continues to work. Now, when this happens, this is going to knock out the penicillins. It's going to knock out anti-staphylococcal penicillins. It will knock out extended spectrum penicillins. It will knock out all penicillins you have ever heard of. None is going to be able to work. Now, when it comes to cephalosporins, first generation cephalosporins are going to be knocked out. Second generation, out. Third generation, out. The fourth generation, or sometimes called the fifth generation, is likely to work. And this is a drug called ceftaroline, but we will come to it when we look at the cephalosporins. It is likely to work, and it can work against these methicillin-resistant Staphylococcus aureus. Monobactams, aztreonam, is not going to work. Carbapenems, none of them is going to work. They're meant to be quite potent, but they are only good when you have beta-lactamases as a problem. But once methicillin resistance sets in, and this is found in the gram-positive organisms, then basically no penicillin is going to work, no carbapenem is going to work, aztreonam will not work, and amongst the cephalosporins, only the fifth generation ceftaroline is likely to work. Okay? I hope you've understood that. Now, there is no harm in me telling you, I'm definitely going to bring a question in this area because this is information that one needs to have. But it is going to relate with, my questions are going to be looking at a number of issues regarding the organisms, the diseases, and the choice of drugs. Now, there is something about these anti-staphylococcal penicillins that makes them a little different from the others. They are metabolized by the liver, and that information is here. So you can always read the notes on this slide, but this information is right here. The dose must be adjusted to accommodate renal function. That's for patients who have renal impairment. But except for nafcillin, which undergoes biliary excretion, and nafcillin is also an anti-staphylococcal penicillin, and also oxacillin, dicloxacillin, and cloxacillin, which undergo biliary and renal excretion. Okay? And the dose can be given about a third or a quarter of the usual dose if creatinine clearance is less than 10. So in general, for patients who have renal impairment, these drugs are likely to work. But then remember that these drugs are anti-staphylococcal penicillins. These drugs are so specific such that they are going to work against staphylococci. They can work against pneumococci as well, where I talk about streptococcal infections. But they will not be able to work against all the other organisms, aerobic or anaerobic. They won't work. And so if you are faced with a situation for a patient who's having renal impairment, and you think, oh no, let me get a drug which is not, whose dose doesn't have to be adjusted in renal impairment, and you think of oxacillin or cloxacillin when you are treating a urinary tract infection caused by Escherichia coli, you would be absolutely wrong, because these drugs are they are not effective against gram-negative organisms, okay? And they are not effective against anaerobic organisms. So if you're treating a patient who has, for example, acne and caused by Propionibacterium acne or Peptococcus, which these are gram-positive organisms, these drugs still are not going to work because they don't work against anaerobic organisms, okay? So this is why it is good to study the tables that I've given you, and to also understand how these drugs generally work. Now, for the rest of the penicillins, okay, including basal penicillin, where we have pen G and pen V, basal penicillin, they are generally excreted by tubular secretion. Okay? They are excreted by tubular secretion, not necessarily glomerular filtration, but tubular secretion. Now, in some patients, they might be having glomerular problems, and without major problems with tubular secretion, such drugs will still be excreted normally. But research has shown that as glomerular diseases, when they are not mild, and they become moderate and severe, that condition does also affect proximal tubular function. And so even though these drugs are excreted by tubular secretion, when you have glomerular disease that is not mild, also the proximal tubular secretion is affected, and therefore dosage adjustment will still be required. Now I'm talking about the other penicillins, okay, which are normally excreted by tubular secretion only. Now I'll just take you through these notes here. Excretion is via the kidneys, 10% by glomerular filtration, which is quite a small portion, and 90% by tubular secretion. In neonates who are less than a week old, the half-life is approximately 3 hours, and about 1.4 hours at 14 days of age, because you expect that the functioning of the kidneys has improved. There's more differentiation. Anuria increases the half-life to around 10 hours. The drug is cleared 7 to 10% per hour hepatically, okay? So of course, the liver will come into play in patients who have anuria. Now, anuria means that there is generally no urine formed, and so the kidneys are not functioning. So the half-life of these drugs increases, and then the drug will be cleared slowly hepatically, all right? Now, there is an important interaction between penicillin and probenecid. Probenecid does inhibit the organic cation transporters or organic anion transporters. We'll check on that and ask you to do the same, so that the penicillins are not picked up by these transporters and pumped into the proximal tubules and eventually into the filtrate and lost in urine. Now, this probenecid therefore increases the concentration of the penicillin in plasma. Now, this information here on clinical uses, I would like you to revert back to the table, because here I list organisms, and this kind of information is not very useful, because by listing these organisms is not, I mean, it won't help you if you're not looking at the particular diseases caused by a specific organism. So you have tables of these organisms and the diseases they are causing, And so you can now say, okay, I can use benzyl penicillin in the management of this particular condition. Now remember that with benzyl penicillin, as the slide puts it, is effective against anaerobic organisms, but also in the notes I added, as long as they are not generating beta-lactamases. And these anaerobic organisms, amongst them, importantly, we have Clostridium species. I told you about Clostridium perfringens, Clostridium tetani. And so you can use benzyl penicillin to treat those. When it comes to Clostridium difficile, you might want to use an orally administered antibiotic. And I'm sure when you come across your clinical practice, you'll see the drugs that are used against that particular condition. Okay, so please revert back to the tables and then associate conditions, specific conditions with organisms, and then you can be able to choose which antibiotic you can use in the management of a particular disease. Penicillins resistant to staphylococcal beta-lactamases. They're active against beta-lactamases producing Staphylococcus aureus, also active against streptococci and pneumococci. I think I've told you that already. So you can always read through these notes that the anti-staphylococcal penicillins can have some effect against streptococci and pneumococci, but not against enterococci, even though the enterococci are also gram-positive organisms, but they are generally resistant to these penicillins. In any case, enterococci are stubborn because they do have some level of methicillin resistance, and so using penicillins against them might not prove to be useful. So other antibiotics will be used. Okay. What I want you to refer to again, these notes do have lots of organisms. The way they appear is not very useful, but use the table. Use the tables that I've given you to talk about how these drugs generally, how they use their clinical uses. But remember, I've talked about the pharmacokinetics, how these drugs are excreted, and we talked about tubular secretion as the main mode of excretion with very little glomerular filtration. But if anuria occurs, I've talked about hepatic metabolism and clearance of these drugs, but at a very, very low rate. And now let's talk about adverse drug reactions. These adverse effects occur with the penicillins. Hypersensitivity. This is important. All penicillins are cross-sensitizing and cross-reacting. Okay? And so once a patient reacts to one, then you can't use another. Interestingly, when we have hypersensitivity to penicillins, it is not advisable to use other beta-lactam antibiotics, particularly the cephalosporins. You don't go there because there is some cross sensitivity has also been observed. Then also anaphylaxis has been shown to occur, and anaphylaxis is a very serious condition. Oral lesions have also been observed. Eosinophilia, hemolytic anemia as well. Desensitization is possible, but why do we go there when we have alternative drugs? So alternative drugs, which have the same, particularly same spectrum as the penicillins, I think we would go for erythromycin. But if we are dealing with some organisms like Haemophilus influenzae and Escherichia coli. Then we would use maybe azithromycin or clarithromycin, which are macrolides. And we will study the macrolides a little bit later. But this is what we have about the penicillins. So we've looked firstly at the classes of the penicillins. The class, penicillins as a class, we've seen their structure. We have seen the subclasses of penicillins, and under them you should be able to mention the drugs in those subclasses. We have looked in detail the mechanism of action of the penicillins. We have also looked at the resistance, the mechanisms of resistance against penicillins. And under these, we've looked at the beta-lactamases. We have also looked at methicillin resistance. So you should be able to, if somebody says, can you explain what methicillin resistance is? You should be able to explain that. Then we have also looked at the pharmacokinetics of these drugs. And we've talked in sufficient detail how the tubular secretion and the glomerular filtration and what happens in patients who are anuric. And then we have finished by looking at the adverse drug reactions. Okay, so that concludes the lecture on penicillins. What I would like you to do in terms of your revision, know all the things we have talked about, but this is something you will not escape. This should be able to classify these organisms, particularly the bacteria, including the atypical bacteria, chlamydia, rickettsia, mycoplasma. These spirochetes, I believe they do have the peptidoglycan structure, and because penicillins are used against them. So you classify these organisms and also do classify these, and that should be your background information, and then bring that information here. We look at pharyngitis, which organisms are causing pharyngitis. Of course, for most of these, you're going to find viral causes, but we are doing antibiotics, so we would like to look at the bacteria causing. So please study respiratory conditions. These are 1, 2, 3, 4, 5, 6. For pneumonia, of course, you're going to have to look at community-acquired and hospital-acquired pneumonia. And then urinary tract. This is what I told you earlier, these two. Because these are the ones I'm going to, my questions. We have a number of these, or many of my questions will be based on these conditions. So I'm calling upon you to study, memorize, do whatever it takes to make this a part of your life. Because then you will be effective in the choice of these microorganisms, rather of antibiotics in the management of these conditions. And do not forget the other parts we have looked at, the different parts, the pharmacokinetics, the pharmacodynamics, and the mechanisms of action, and adverse drug reactions, and the classes and subclasses of the drugs. Now, all our lectures are going to be having this kind of thing. Now, when it comes to these organisms, this is a once-off. It will show up for different antibiotics that we are going to look at. Because after this now, we are going to do cephalosporins, but I will not go through much detail because cephalosporins are beta-lactam antibiotics. We will also go through the carbapenems because they are also beta-lactam antibiotics. But I'm not going to spend too much time there because we now know the mechanism of action. We know the mechanism of resistance. So we'll just be looking a little bit at the pharmacokinetics of those drugs. And then the spectrum of effect, because the first generation cephalosporins, as we extend forward, the first generation are effective against gram-positive organisms more than with the gram-negative. And as we move to second generation or third generation, we are increasing the spectrum of gram-negative, of effect against gram-negative organisms. Okay, so we will study those next. Then when we are done with that, I've uploaded a Word document for you, which has all the other antibiotics we are going to be looking at. The tetracyclines, the macrolides, the streptogramins, lincosamides, and many others. We do have the notes, and I implore you to read as much as you can. So I'm going to upload notes on the cephalosporins now. You can always go through those slide notes as well in preparation for our next lecture. I'm giving you time to prepare for your test is it surgery? Yeah, so that we can always handle this content.